Muchas gracias, genial. Bueno, pues ahora...
Very well. Now you have them right there in the target zone. You can ask them, hello, can you hear me? Yep, perfect. So you have them in the target zone. Ask away. They're happy to answer your questions. First question or remark. Yes, Clara, a question. You have shown some data and you've spoken very, very fast. It was 51 years and 49 years. When you show the data of deaths, the mean average death, 49 and 51 years of age, or I didn't see it because you were pretty much breezing through it. Because really, we're talking about people that, I mean, the database, how does a patient presented with Wilson's disease, patients that require hospitalization, but I really don't understand where you get that mean age for deaths. You're talking here, if you can explain, because I'm just flipping out here. For Wilson disease, we have main sources, the CMBD, which are discharge data of patients that were not admitted because of Wilson disease, but then they had also a Wilson disease diagnosis. Then we have the registry of, they don't need to die because of WD, but they could die for any other cause. And what we have added in the last years, and the limitation that we had with rare diseases, we no longer have it, is primary care. So primary care, so it is true that for rare diseases that are not severe, in this database, we need to have more specialized cases and data, because, I mean, this is not representative. Here you're saying death mean age is 44.9. That does not represent all the patients, all Wilson patients. Yeah, because death mean age, it's like, well, because if you just look at this out of the blue, it's really something. Primary care has not been taken into account. We only have Murcia and Castilla-León, two autonomous communities, have also provided information. So you need to do appropriate screening because they do a lot of false positives as well.
Because there are actually a number of studies that there's a great, the large Austrian study, and there are also other studies that suggest that in well-treated Wilson patients without complications, the life expectancy, that is how old you can expect to be, is very close to the normal population. And I guess that you react because 51 years is somewhat lower than the normal population. But I think the general point of view is that in a well-treated patient with Wilson's disease, the life expectancy is normal or close to normal. If patients have severe complications, for example, severe cirrhosis of the liver, there may be some reduction of the life expectancy, as one perhaps would expect. But so I think this is a preliminary presentation of data from a health registry. There may have been a tendency that the more severe cases are being recorded with a higher frequency than the less severe cases, and that is also what you explained. So I hope that helped you understand.
Yeah, thank you very much.
Y un poco en la misma línea.
And along the same lines, Susana, the issue we have with the registry is that we have different registries from different perspectives. This is pretty much general population registry that will relate it to severe cases. But here we have from pathology, and it's more related to what Peter has said. Most of the patients included in the registry here in Spain for the hepatic study, we have 415 patients in that registry, and most of them have a very well controlled and treated, and the mortality rates are not that. The mortality rate is much lower and definition. But here, what I probably didn't say is that the cause of death does not necessarily say Wilson's disease, but those 8 patients that were there. So that's why the numbers are different. Thank you so much.
Presentation. My question, I just had a woman who came to my clinic and she's pregnant and she was diagnosed through the lab tests that were done now in her second pregnancy. I'm still going to have to finish the examinations, but we'll have the results. What drug do you utilize when it's the first diagnosis in the pregnancy?
Well, I don't think there is an answer that can be based on evidence. I mean, but personally, I would start penicillamine, just as if she was not pregnant yet.
¿Más preguntas? Lo hemos dejado todo claro.
Hola.
Hello. I wanted to make a remark regarding Dr. Peter Ort.
You mentioned very interesting data about how Wilson's disease affect pregnancy. I understand that you presented the perspective where the mother is the Wilson's disease carrier. Do you also have any data on the cases where the mother does not have Wilson's disease but the father does? So I wanted to ask you, do you have any information on that? May that affect also the chance of spontaneous miscarriage? And would you also advise to do any specific monitoring on the mother, even if she doesn't have Wilson's disease but the father does?
Well, it is known that fertility, the ability to produce a pregnancy, so to say, of men with Wilson's disease is normal. So the ability to become a father is normal if you have Wilson's disease. The risk of the baby getting Wilson's disease is of course the same as if it is the mother who has it. There's no reason to make special examinations in the mother during the pregnancy. I think that was all the questions.
Thank you.
Peter, I will also make you a question. Where you were talking about reducing doses of the penicillamine and trientine as recommended in the guidelines during pregnancy. Do we have to reduce the doses at the beginning of the pregnancy, or is it at the end of the pregnancy in third trimester? Because there are some discrepancies in the guidelines at the field.
The most recent guideline, the American from last year, recommend that you do it from the beginning. So, and that is, I think it's not much explained, but I think it's a trade-off that if there is a risk of teratogenicity, it's more important in the beginning. And if there is effect of the baby taking up copper from the mother, is more prominent in the end of the pregnancy. So they say, well, let's average it out and make it simple. Earlier guidelines suggested the earlier guidelines actually suggested that it was only in the last trimester, but I think it makes sense to do like the Americans suggested.
And on the same line, at what point will you turn to the initial dose of the treatment? Is it at the moment of delivery, or would you stop a little bit, or would you wait a little bit to start the doses, the plain doses?
I think the guideline, the American guideline, has a suggestion of a few weeks after birth to make sure that the wound healing is finished. And that makes sense, I think.
Zoe, una pregunta.
Zoe, I have a question. Patients sometimes have a transaminase that could be elevated. In those patients, how many times do you retake that systemic study? Because they could be presented with other pathologies, not just because you have Wilson, you're only going to have WD. So you follow them up for years. Do you do the study? Do you do autoimmune hematocrosis? Do you do everything? You do ferritin test? Do you, fatty liver, of course? And how far do you go? Do you repeat the battery of tests again and again? Yes, this is a very good question, because that is something that we see in our clinics. It is very hard to give you an answer. If a patient was presenting transaminase that were normal and now they're not so, you need a complete assessment because you need to discard any other diseases. You need to have make sure that you don't have pharmacology toxicity, or that you don't even have natural products toxicity. You need a very good clinical interview, and if I am sure that that person is controlled from the copper point of view, I will move forward through even towards biopsy. If I'm not certain that I have full control of the copper, I believe that the key is to detect if we're falling short or if we need to change treatment. And we have had experiences recently with patients that when we change the medication and we went from medication to killant agents, they go to normal transaminase levels. An important message maybe here to everyone to take home is to remember that transaminase that not imply severity. And we need to be patient, and we need to make sure and see and give it time and see, especially if we do a switching, especially if we have a preserved hepatic function. We need to research more and better and take care of the comorbidities, because we have a lot of patients now that are drinkers. Maybe you see, we the adults are a little bit regarding alcohol. We like a couple of glasses of wine here and there. We could have fatty liver. And remember that if you have a Wilson disease patient, you already have a damaged liver patient. And, we need to think of the comorbidities. You can make sure that you're strict enough. We don't have any other questions or remarks. We are hungry. That's, yes. I don't know if it's clear or not, but definitely you all are and look hungry. Since everything is clear and nobody wants to ask from the association